from dislocation to clarity, managing an old traumatic anterior misplaced intraocular lens and corneal bulle. Intraocular lens or IOL dislocation is a known complication of cataract surgery, which may occur early or late, with an approximate incidence of 0.2% to 2.8%. Although posterior dislocation is more common, the anterior dislocation can be visually significant. Long-standing, unmanaged anterior IOL dislocation leads to complex anatomical changes, including haptic iris adhesions, corneal endothelial compromise, and anterior chamber instability. In this video, we are going to present a technically challenging IOL exchange surgery in an old case of anteriorly dislocated single-piece rigid IOL, complicated by iris haptic fibrotic adhesion, optic fragmentation failure associated with partial corneal endothelial decompensation. 50-year-old Indian female presented with significant vision loss and irritation in left eye since past 1 year. Her cataract surgery was done in the left eye 8 years ago. She had a blunt trauma in the left eye which was managed elsewhere by conservative treatment. Her best corrected visual acuity at presentation was counting finger at 3 feet distance. On slit lamp examination, the optic of the IOL was seen forwardly dislocated, resting over the pupil, with incomplete view and orientation of the haptics. There is pupillary ectropion UV and iris pigmentary changes. Cornea has few epithelial bullae with localized stromal edema around inferonasal area. The endothelial count was 1545 per millimeter square with central corneal thickness of 580 micron. USGB scan showed normal posterior segment and pachymetry analysis revealed increased epithelial thickness at the inferonasal quadrant. Failure of the conservative treatment and the progressive corneal endothelial decompensation necessitated surgical intervention. Given the complexity of the case, the surgical plan was aimed at safe and atraumatic explantation of the IOL without further damaging the adjacent structures. Precaution was also taken to possible preservation of capsular support and secondary IOL implantation either in the sulcus or inside the capsular bag. Under peribulbar anesthesia, a side port was made at 10 o'clock position, and dispersive along with cohesive viscoelastic were injected to protect the endothelium and to adequately deepen the anterior chamber. A dialing instrument was introduced at superior optic haptic junction of the PMMA IOL to dial it clockwise to make it free from the superior angle. But rotating the IOL further, it was noticed that the lower haptic has perforated the iris and densely fibrosed with it at the inferior angle. But repeated dialing remained unsuccessful. After injecting a little viscoelastic, pulling out the haptic from the entanglement with a microforceps could not help. Rather, a great attraction caused an iridodialysis along with fresh hemorrhage from the angle. Next, I tried to cut the fibrous tissues wrapped around the haptic to make it free from the iris fibers with micro scissors and tried to gently pull with dialer again, but it did not work. At this moment, I planned to cut the inferior haptic from the optic by a IOL cutting scissors. Another side port was made at 2 o'clock position and previous one was enlarged. Viscoelastic was injected and stabilizing the inferior haptic with dialer. The cutter was used to cut the haptic at the haptic optic junction and the optic was successfully separated. Now an attempt was made to bisect the optic by same IOL cutter. After injecting viscoelastic, main incision was enlarged. IOL is properly positioned and fixed with spatula. The IOL cutter was introduced, but it was difficult to grasp. Now the IOL was stabilized with micro forceps from the left side port. But the cutter was failed to bisect the hard rigid PMMA material even after repeated attempts. Now the incision was further increased to remove the whole optic along with one intact haptic, although wasn't the original plan, but it was the safest path forward. Posterior synechiae was released from the capsular bag. And a +20 diopter, 3-piece IOL was put into the bag after checking for capsular integrity. The large wound was closed with tenno nylon. Viscoelastic was removed and sutures were buried. Air bubble was injected into the AC. Localized anterior stromal puncture was done over the bulle. The hypertrophied epithelium was removed there, and a BCL was applied over the cornea to remain for 1 month. Post-operatively, antibiotic steroid drops and lubricant was prescribed. After 1 month, her corrected distant visual acuity was 20/40 with Manas 3.5 diopter spherical power. The cornea has a small area of localized edema inferiorly with endothelial cell density of 1340 per square millimeter and pachymetry of 541 micron. The eye was doing well after 2 months with a normal fundus, and at 5 months with a stable distant visual acuity of 20/40. This case underscores 5 vital lessons for any anterior segment surgeon. Long-standing IOL dislocations may not follow the expected course and may end up with fibrotic tissue development even in quiescent cases. Preoperative imaging is essential but not infallible. UBM or high-resolution anterior segment OCT may help, but prepare for surprises. Have multiple IOL cutting and explant strategies available. Don't rely on a single technique. Know when to pivot. When intraocular sectioning fails, externalization can prevent further damage. And try to protect the endothelium. Use viscoelastic generously and minimize chamber turbulence. So to conclude, the real skill in surgery isn't just executing a plan. It's knowing when and how to change it. Thank you.